My lecture today will be on the type of seizures or epilepsy. The 2017 classification of seizure types has divided the seizures into focal, generalized, and unknown onset. In the past, we call partial onset or generalized onset. Under focal onset, it was further divided into aware and impaired awareness seizures. In the past, we call simple partial or complex partial seizures. Please note that under focal onset, there is automatism as well as hyperkinetic seizures, which was not present under the group of generalized onset seizures. In addition, there are also aura commonly seen related to focal onset seizures, as well as asymmetrical presentation in focal onset seizures. For example, focal tonic-clonic seizures or asymmetrical tonic seizures, which is different from symmetrical bilateral tonic-clonic seizures in generalized onset epilepsy. Why is it important to differentiate focal from generalized onset seizures? Because the etiology, medications, prognosis, and the option for epilepsy surgery will be different. In focal onset seizures, the common cause is structural, and therefore there is a need to do neuroimaging, whereas in generalized seizures, especially childhood onset or juvenile onset seizures, imaging may not be necessary. The medications will be mainly carbamazepine as compared to valproate in generalized seizures, and in focal seizures, most of them will be refractory as compared to most in generalized seizures, which will be responsive to anti-epileptic drugs. However, in focal epilepsy surgery can be an option in suitable surgical candidates. In order to differentiate focal from generalized onset seizures, firstly, we must describe the seizures, and we call this semiology. Semiology can be divided into pre-ictal, ictal, and post-ictal phase. In the pre-ictal phase, we are mainly describing the aura, which include autonomic aura or psychic aura, such as fear, déjà vu, epigastric sensations, which is commonly seen in temporal lobe epilepsy. Sensory aura, for example, numbness, paresthesia, tingling in one side of the body usually came from parietal lobe, whereas auditory aura, either a simple or complex aura, are from temporal lobe, and visual aura is from occipital lobe. For the ictal phenomena, we need to describe the head, eyes, face, mouth, limbs, and body. The head can be deviated to one side, but if it's forceful, we will call that versions. The eyes, although it's usually uprolling in generalized tonic-clonic seizures, but in focal seizures, it can be deviating to one side, and sometimes we may notice nystagmus. The face, beside dividing them into tonic or clonic seizures, we also need to describe whether they are unilateral or bilateral. Whereas for the mouth, it's important to note oral automatism, which is commonly seen in temporal lobe epilepsy. For the limbs, similarly, beside tonic and clonic descriptions, we also need to note whether it's symmetrical or asymmetrical, and whether there are automatisms of the limbs, and whether they are very violent, aggressive movement in hypermotor, or we call hyperkinetic seizures. In description of the body, atonic seizures is usually seen in drop attack, but sometimes you will see tonic contractions of the neck, causing neck flexions, or tonic contraction of the abdominal muscles, causing the patients to sit up or to bend their body. Thrusting can be seen in frontal lobe epilepsy, but is commonly described in those with psychogenic non-epileptic seizures. In our first case, the patient has myoclonic seizures, which is described as sudden brief involuntary movements. This can be single or multiple and usually occur in the early morning. As you can see in this young man, he has multiple jerks of the upper limbs, and some are single, some are multiple. The onset is 12, and therefore we call this juvenile onset epilepsy. The semiology include myoclonic jerks, and the types of seizures generalized onset, specifically myoclonic subtypes, and the epilepsy syndrome will be juvenile myoclonic epilepsy because of juvenile onset, predominant myoclonic seizures in these patients. The second types of generalized onset seizures is absence, which will be described further in staring spells lecture, and I won't cover in this lecture. Generalized tonic-clonic seizure can have a focal or generalized onset. If it's focal onset, we'll call it focal to bilateral tonic-clonic seizures. The diagnostic tips toward focal onset include the following. Firstly, in examination, we will look for focal neurological signs like hemiparesis or dysphasia. The presence of aura will also suggest this is likely a focal onset. Asymmetry presentation in the seizure itself, especially head turning or version, eye deviation to one side, or asymmetric limb tonic posturing. If there is a post-ictal focal phenomena like hemiparesis or dysphasia, this is also suggestive of focal onset seizures. Similarly, in focal neurological neuroimaging abnormality. Age more than 20 is commonly focal onset because in those generalized onset seizures such as childhood onset, childhood absence seizures or juvenile myoclonic epilepsy, the onset is usually before 20 years old. The second case is a case with temporal lobe epilepsy. Commonly, patients have aura of autonomic features or psychic features. They may have blank staring, oral automatism, contralateral dystonia, and ipsilateral automatisms. Some of them have amnesia. In this video, you can see that the left hand is in a very dystonic posture, and we don't call this a tonic seizure. The right hand has repetitive movement, which is an automatism. The son is trying to call him, but he is unresponsive and he is blank staring. And now you can see oral automatism at the end. The onset is 43, and this is very refractory to seizure medication. So answering the questions, the semiology is as described, including epigastric aura palpitation, which is autonomic onset, blank staring, left dystonia, right automatism, and oral automatism. The dystonia is usually contralateral to the lesions, and when the patients have left dystonia, it usually indicate right-sided epilepsy. So what type of seizure is this? This is a focal impaired awareness seizures with an autonomic onset and behavioral arrest as well. Subsequently followed by automatism of the limbs as well as the mouth. What type of epilepsy is this? This is a case with temporal lobe epilepsy, and sometimes specifically we can lateralize it, and for example in this case lateralize to the right side because of left dystonia. Frontal lobe seizure semiology can be divided into various types, depends on the anatomical locations of the seizures. First is the primary motor seizures, which usually presented with focal tonic-clonic seizures. For example, in this patient, he had left face tonic, and in the later stage, he will have clonic jerks as well of the left face. The second anatomical regions is frontal eye field, which usually presented with versive seizures. As shown in this picture, the patient has a very forceful head turning to the left, which is called left versions. Orbital frontal seizures normally presented with hypomotor features, as what we have seen in our case number 3, where the patient seizures occur at night with violent kicking and jerking and turning to the right side, and usually these seizures are very brief and patients will continue sleeping after the seizures. Supplementary motor area will have seizures which is called asymmetric tonic seizures, whereby in this picture you will see the left hand is flexed, the right hand is extended, and they are asymmetrical in the limb tonic movement. Whereas for seizures from medial frontal regions, they normally presented with asymmetric tonic seizures with prominent automatisms. There may be some overlaps of these features depending on how the seizures spread from one region to another, but this is just a rough guide associating the seizures type and the anatomical location of the epileptogenic zones. So for case number 3, the patient have sleep-related violent kicking, turning to the right side, and we'll call this focal impaired awareness seizures. The specific subtypes will be hyperkinetic or hypermotor seizures. This is an example of frontal lobe epilepsy. There are some features differentiating frontal from temporal lobe epilepsy, although it may not be definite. Firstly, frontal lobe occur mostly at night during sleep, whereas temporal lobe occur in the daytime. Temporal lobe will have a lot of will have various types of aura, including epigastric aura, aura of fear, deja vu, and other psychic aura as well. Automatism in temporal lobe epilepsy are usually distals, involving the hand, and sometimes there are oral automatisms, whereas for frontal lobe, the automatism is proximal, for example, hyperkinetic seizures. Generalized tonic-clonic seizures occur early in frontal lobe epilepsy, whereas in temporal lobe, they are usually a late feature. Therefore, I conclude my lecture by describing different types of seizures and show you some of the cases. Thank you very much.